the endometrium. And this is an important symbiotic effect of bacteria on the lining of the endometrium, macrophages, and tolerance and development of Tregs. So this is to say that pregnancy at the beginning is behaving like a tumor, controlled tumor, and not as a transplant, as is usually believed. The second note I want to share with you is that, yes, the uterus is open, but it's a complex control environment, and it is controlled by natural immunity and by acquired immunity. So it's not the Pentagon, it's something like the Vatican, but there's a lot of Swiss guards guarding what is happening in the uterus during pregnancy. And the third background note, which is really, really important for the purpose of premature delivery, is that of all the anthropoid monkeys, we are the only species in which at the end of pregnancy, the human end of pregnancy, progesterone keeps on being produced by the placenta at the same rate as during the last weeks of gestation. And in order to allow for estrogens to induce prostaglandin and oxytocin receptors, we develop decoy receptors for progesterone. We are the only mammalian with this mechanism, because all mammalians go to hand with declining progesterone. We are the only species in which the progesterone is steady, but we develop the decoy receptor. And how does it happen? It happens because fetal T cells invade the myometrium because of stress, inflammation, and inflammation starts this chain of events which goes to delivery. So we are a species who is delivered prematurely. And in fact, we need an extra gestation, because even chimpanzees, which are very close to us, they deliver a baby who is already competent, who can hug the mom and flee with her in case of danger, can hug the mom, jump on her, get the milk, get to be hugged. We have an extra gestation. Our newborns are unable to do anything to get together with the mom. So we are born altriciality. So that means that prematurity is a way down, something which is already present in physiology. Any kind of inflammation activate the mechanism of natural delivery. So there is a competition between the mother and the fetus when there is an inflammation, because the mother wants to get rid of the inflammation, the fetus and the placenta, and the fetus wants to stay there because he wants to survive. So when we are dealing with a premature delivery, we have two patients who might have opposing interests for life. The mother wants to get rid of the baby under the placenta, and the baby wants to stay inside. So what do we do? Which is our best option? So I think that so far, most of the protocols and guidelines are not really including the heap of the enormous amount of biological knowledge that has been developed in the last 20 years. So if we look at guidelines, we are stuck in a maze. We do not know where to go. So we know we have just to collect the clinical history. We are able to measure the cervical length. We can measure the white blood cell counts. We perform vaginal swabs, whatever they serve. We deliver antibiotics only in PPRO. And then if we use tocolytic, it is just for 48 hours, just for the betamethasone to be active on the fetal lung. Is it enough? No, I think this is prehistoric. It's a stone age in terms of the relationship between biology, knowledge, and what we are doing in the clinical practice. So I want to start to focus on two different, main different phenotypes. The gray one, in which at different gestational age, we see that there is no intraamniotic inflammation, And 15, 20, 30, 33% is a percentage of cases of delivery before term without any evidence of intrameiotic inflammation, idiopathic premature delivery. The red zone is clear. The red is microbial associated intrameiotic inflammation, and the blue one is sterile intrameiotic inflammation. So these two phenotypes, the gray and the red-blue one, are completely different in terms of what we can find in the placenta, in the amniotic fluid, and what probably we could do different, we could behave differently. So let's start from the thing which is the part of it which is easier to understand and probably to treat. And it is caused by early inflammation or acute inflammation, and it has to do with innate immunity, with the reaction of innate immunity. We know that maternal neutrophils, they circulate in the intervillous space, and when there is a chemotatic gradient between the amniotic fluid, the membranes, and the myometrium and the intervillous space, they migrate into the placenta. And they start a cascade of events which leads to intrameiotic inflammation as a reaction to bugs, to bacteria. On the fetal side, the white blood cells of the innate immunity of the fetus, they start to lead the vessels and reach out of the tissues where bacteria are trying to develop. So this is what is known as fetal inflammatory response syndrome type 1. It's acute chorioamnionitis and phagocytitis, and we see that the very common marker of this condition is IL-6, the interleukin 6. You see on the right side of the panel, the red column, which is significantly higher than the blue one, that is in acute chorion amnionitis, ACA, the marker is interleukin 6. Whereas if we look at the chemokines, which is characteristics of acquired immunity, CXCL10, they are not different in this type of fetal inflammatory syndrome. And what is happening when the fetus is suffering of this inflammatory response syndrome? Well, cytokines, inflammatory cytokines, they reach the pulmonary circulation and the brain. So they create a damage to the brain and to the lungs, which is critical for survival and is critical for the long-term outcome. So we really need to know what to do in this case, and I'll show you what we could do to improve the outcome rather than just looking at what is happening, giving tocolytics and betamethasone and waiting for the nature to do its business independently of what we are doing. Well, this syndrome, this fetal inflammatory syndrome type 1 is an evolving process. It's not something that happens in a minute. And so we could have time to modify what is happening. This is a beautiful study by Irina Buhimishi. It's an old one, it's 2010. And she showed that defensin and alarmins, S100A12, that is protective intracellular protein that we can find in the amniotic fluid. When these defensive proteins are low, the green line, in spite of contractions and clinical signs of premature labor, the pregnancy goes for days and weeks, possibly to term. When instead these defensin and alarmins are high in concentration, delivery will occur soon. These were human cases in which, in front of labor, threatened labor, preterm labor, the amniotic fluid was sampled and the mass spectrometry was undertaken to profile these markers of inflammation. And if we correlate these markers, the red level of alarmin and defensin versus the green, we see that there is a correlation with the stages of chorioamnionitis, the stages, the grades of choriodeciduitis, and the grades of amnionitis. So this is a process, is an ongoing process. And what is happening actually is that at the beginning, the natural immunity responds to invasion of bacteria. But when the level is as high as to create a self-sustained intracellular damage, the release of damage-associated molecular patterns, cells are undergoing a process which becomes independent from bacteria. It's an out-inflicted damage, an overshooting of the immune system. And again, there is a correlation. If you look at the amniotic fluid, there is a correlation you see in terms of time to delivery in days. If both the culture of the amniotic fluid is negative, the black numbers, or is positive, the culture, the red plus or the green plus, or the maternal PCR is negative or positive. You see in the table that the mean there is a correlation in days when these two markers are positive is 1 day, okay? If one of two is positive, the time to deliver is 4 days. If both are negative, the time to delivery is 4 weeks. So if we look at the amniotic fluid and we take care of the maternal inflammatory condition, we can have a good prognostic sign of what is going on in utero when we sample the amniotic fluid. And by this paper by Romero and co-workers, we see that if we have a microbial associated intraamniotic inflammation, just a few cases, but very clearly designed, we can check on the white blood cell count, very high, 295 white blood cell per field. The glucose is very low, 11 instead of 29 or 22. And interleukin 6 is very high, 96. So in these cases, we know exactly that we are facing a condition, we have a bacterial invasion, we have an intraamniotic inflammation, we have cytokines reaching for the brain and for the lung and damaging these tissues. Okay. And there is a correlation between neonatal morbidities and the histological stage of chorioamnionitis and pneumonitis. So we learned this from the Journal of Perinatal Medicine. So there is a relationship from what is occurring under our eyes when the patient is admitted, when she's contracting, and we just look at the contraction and we don't look at the amniotic fluid. And there is a relationship between what is happening inside the uterus and the outcome of the baby. The second syndrome is, again, I go back to this image, the gray part of these columns, is something which is completely different and more difficult to be interpreted in a clinical basis and more difficult to be treated. So it is idiopathic preterm labor. You see that you have fetal T-cell activation, whereas in the lower panel, you have the fetal immune activation against inflammation infection. So you have neutrophils and macrophages in the lower panel. We have seen it before. We have fetal CD4 T cells and fetal CD8 T cells and the different patterns of chemokines producing inflammation and reaction against the environment, the intrauterine environment. So in this case, again, the mother is reacting to chemokines arriving from this reaction, inflammatory reaction without bacteria on the fetal side. And this is a cause of what is called chronic chorion amniosis. And if you look at the placenta, we find this strange mixture of maternal T cells. This is a section of a villi, okay? You see maternal T cells, the small round light blue images, is full of off-Bowers cells that are fetal macrophages from the placenta migrating into the villi, and you have a damaged syncytial trophoblast. So the villi are damaged, and the quality of cells inside is a mixture of maternal T cells and fetal off-Bowers cells. So this is a fetal inflammatory response syndrome type 2, and the partners of this condition are T lymphocytes, and the chemokines are completely different. You see that the CXCL10 is playing the same role that in the type 1 is playing IL-6, which is normal in this case, whereas it is increased in this under this condition of inflammation. Well, I just quoted a few of the 100 papers describing what is happening inside the uterus, what is happening at the level of the placenta, what is happening at the chorioamniotic membranes. So if the snake of science were a positive biting his tail and going on in proceeding the quality of care, but this is not the case for premature delivery. We see that we are still stuck in a very poor pragmatic attitude toward premature delivery. To make things worse, and this is an area of recent investigation, and is a role of viruses, which has been neglected for some time. And the message of this cartoon is that if together with the commensal bacteria, we have also viruses in the endometrial cavity, they play a very negative role. They superactivate the macrophage, and they create an inflammatory condition which is against physiology and responsible for spontaneous abortion and preterm birth. But the viruses might play another terrible role in fetal inflammatory syndrome. This is a cartoon which shows that if we have just a virus on the placenta of a mice, and we just inject a control, we have a mice with a control and lipopolysaccharides, group 2. You have a mice which is injected with virus, and then with the bacteria stimuli. You see that the two things together, virus and bacteria, they make the reaction of IL-6 very, very high. So it's it is a kind of double strike which superimpose and create more damage. So when the poor fetus is facing this double strike, virus and bacteria together, the reaction is even worse. Well, I'm going to the conclusion presenting some data. There's a poor guy in the sand. Is a doctor in emergency room attending a woman with a threatened premature labor, and there is a schism between what is science and what is the clinical protocols. For instance, just to quote one, if you look at the Royal College,